the invitation, and I'm pleased to be with you in celebration of your award of the PEDNET grant. Those of us on this side of the Atlantic are worried about our research funding and the ability to even conduct research under the current administration. So we will be looking to you all for many of the insights that I'm sure will come from this study. Let me share my slides and get started. Let's see. Hang on. Any idea what I do here?
You drag it.
Let's see. Hang on. It's connecting. Shoot. Sorry, guys.
Just share your entire screen and then just go to the slideshow and it should pop up.
Yeah, let me share the entire screen. And then, all right. Is that showing up for you?
Yes.
Ah, great. Okay. Well, thank you again. Uda asked me to talk about ME, CFS in children and adolescents and to give a primer. And I'll largely draw from our experience here. I have no relevant financial disclosures. And the outline of what I'd like to talk about is first to describe older and I think now obsolete views of the pathophysiology of ME/CFS. Then go on to describe how the U.S. Institute of Medicine has created criteria for the diagnosis, and we'll talk a little bit about the evidence for those criteria. And then I want to go into the clinical presentation, some of the epidemiology and the impact of this illness, and then talk largely about how we have formulated our clinical evaluation and the evidence-based options we have for treatment. So looking at the older views, many of these focused on the fact that the illness disproportionately affects females, and the older data focused on those of an upper middle socioeconomic class. And the idea was that the multiple symptoms patients presented with were thought to be consistent with a psychosomatic origin, largely based on the fact that the examination and the laboratory tests were thought to be normal at the time. And from all those observations, the theory emerged that this illness stemmed from somehow abnormal cognitions about the symptoms, and it therefore would be amenable to cognitive behavioral therapy. And I want to try and show you that those concepts are incorrect and the evidence is not supportive. One of the books that was published back in 1992 by a medical historian was focused on this, and he said that our culture witnesses a kind of collective hypervigilance about the body and a readiness of a large number of people to cling tenaciously to a given diagnosis, by which he meant chronic fatigue syndrome, refusing to abandon their belief despite medical reassurance to the contrary. Now, as a medical historian, he had a lot more faith in medical reassurance than I think many of us as physicians do. But this put the patients in a very difficult situation where if they really felt that they were truly sick and kept insisting that somebody look at the illness, they were thought to be even more likely to have a psychosomatic problem. Papers like this emerged where there was said to be a low yield of the physical examination. And then the PACE trial came out in 2011, and that showed that graded exercise therapy and cognitive behavioral therapy were better than specialist medical care alone. But I want you to, we'll talk a little bit more about the methodologic problems of the PACE study, but look at the y-axis. This is quite a misleading graph because they've chopped off the fatigue score from 18 down to 0. And really what they showed, even if you take this study at face value, was only a 2-point improvement in the Chalder fatigue scale after a year of treatment. And that's really not very much to write home about. So let's look at the recent Institute of Medicine criteria here. This was a study that was published in 2015. I was on the committee that developed the new definition. And we spent about a year looking at about 10,000 articles on the illness and tried to come up with an evidence summary. And the concluding comment by the chair of the committee was that ME/CFS is a serious, chronic, complex, multi-system disease that often can profoundly limit the health and activity of affected patients. We came up with core symptoms to simplify the definition. The first was a substantial impairment in the activities that were well tolerated before the illness, usually accompanied by profound fatigue, but we wanted the emphasis not to be on the single symptom of fatigue, but on the impairment in function. The second core symptom was post-exertional malaise, and the third was unrefreshing sleep. And then you could have either cognitive impairment or orthostatic intolerance. Now, orthostatic intolerance was seen in more than 95% of the pediatric patients, but at least in the literature at that point, only 40% in the adults. And I'll come back to that 40% number a bit later. Post-exertional malaise, one of the key features, as you all know, is an increase in a variety of symptoms after physical, cognitive, or it turns out orthostatic stress. And we've shown that this can occur after biomechanical strain, such as with a simple straight leg raise test. The symptoms are widespread and they can mimic the kinds of things that one might see in a concussion. In adults, especially, the PEM onset can be delayed by 24 hours, but many patients know that this can extend well beyond 24 hours in duration. One of my favorite studies on that adds some objective data to the concept of post-exertional malaise came from Alan and Kathleen Light. They did a 25-minute exercise on a bicycle to 70% of the predicted maximal heart rate. And at baseline and at several intervals over the next 48 hours, they measured peripheral blood mononuclear cells looking for evidence of gene expression changes in pain pathway genes. These are the ones labeled sensory, genes that affect circulation, the adrenergic pathways, and then genes affecting the immune system. And you can see at the top that the healthy individuals had very little change in gene expression over the 48 hours after exercise. When you look at the ME/CFS patients, they had a peak of an up to 9-fold increase in some of the adrenergic genes at 24 hours, precisely when the patients were reporting increased symptoms. And so they had about a 3-fold increase in the pain pathway genes, a doubling of the immune genes. And so this helped add some objectivity to the subjective complaints that patients had consistently been reporting. And this work has been replicated by others. In terms of orthostatic intolerance, we know that this can bring on a wide range of symptoms. The ones in the left column are typically thought to be due to reductions in brain blood flow. So that makes sense for lightheadedness, syncope, diminished concentration, and others. And in all forms of orthostatic intolerance, there's an increased prevalence of fatigue and intolerance, especially of low impact exercise. On the right are symptoms that are thought to largely, but not exclusively, be the result of the reduction in brain blood flow, the sympathetic nervous system's exaggerated response to that reduction in brain blood flow. And that can include chest pain, palpitations, tremulousness, anxiety, and so on. The main forms of orthostatic intolerance that we see in pediatrics are postural tachycardia syndrome on the left. This is an individual who did a passive standing test and had an over 40 beat increase in heart rate that was sustained together with reproduction of symptoms. So POTS requires a 40 beat increase in adolescents 12 to 19. From 20 on, you need a 30 beat increase. It has to occur in the first 10 minutes of being upright with orthostatic symptoms and without orthostatic hypotension in the first 3 minutes. On the left, or sorry, on the right is the pattern that we saw when we began our research in the early 1990s. This is neurally mediated hypotension, which is synonymous with the physiology of vasovagal syncope, but not all the patients have had syncope in day-to-day life. So we termed it neurally mediated hypotension. We are guilty of making it more complicated than it should have been. In any event, here's a medical student who is having all kinds of fatigue and pre-syncope. As she went up on the tilt table to 70 degrees, she was initially lightheaded and pale, and then at the 5 to 6 minute point, the bottom fell out on blood pressure, and she had a slowing of the heart rate at the time of hypotension, with some tonic-clonic movements. And so that pattern is another one that can be associated with recurrent and chronic fatigue. Another finding that we've learned to look for is acrocyanosis. This is a standing test performed on a young college student who had to stop her studies. On the left is her hand after 5 minutes of standing, with my hand there for a color contrast. On the right, I've done a capillary refill test where I've compressed her skin, walked back to my desk, found the phone, looked for the camera icon, and then took a picture. So after about 7 or 8 seconds, she still had no adequate capillary refill. And this is a profound physical abnormality that you can see in up to 75% of the patients. We got interested in the connection with orthostatic intolerance when I was running a diagnostic problems clinic in the early 1990s, and we wrote a case series of 7 patients consecutively tested on the tilt test, in whom we could reproduce their fatigue when they were upright, and they all developed the neurally mediated hypotension pattern. And we continued these studies with Issam Bohalega in the picture. He's from Saudi Arabia, and Hugh Hopkins, who runs our tilt table lab. And we went on to publish a larger study that was mixed with adults and adolescents. And in that study, we had 23 with ME/CFS and 14 controls. So it was a small pilot study, but we were able to show that when we tilted people upright, they had a bad day with their ME/CFS symptoms. They all had worse fatigue, they were lightheaded, they had hot flashes and nausea, whereas the controls left upright for 45 minutes were simply bored. We then went on to treat people openly, not in a randomized fashion, but openly with fludrocortisone, midodrine, stimulants, beta blockers, a mix of medications typically used for orthostatic intolerance and syncope. And we showed that with open treatment for 4 months, the mean score on the wellness scale, 0 to 100, with 100 meaning optimal health, went from a mean of 35 to close to 70 after 4 months. And this is the pattern we continue to see to this day. And that is why we talk about orthostatic intolerance as the most treatable component of ME/CFS. Not in every single patient, but by and large, that is true. Now, remember I said that in the Institute of Medicine report, only 40% of the adults were thought to have orthostatic intolerance. And then along came Frans Visser and Linda van Kampen from Amsterdam. I met them at a conference in Bristol, and we started working together on their data. I was mainly helping with some of the scientific writing, but primarily helping to adjudicate arguments between Linda and her husband, Frans. So these were all their data. They had a huge group of patients, 429 adults with ME/CFS and 44 controls. Notice that they had about a 40% prevalence of demonstrable hemodynamic dysfunction. So 28% of the adults had POTS, 14% had delayed orthostatic hypotension, and the vast majority, 58%, had a normal heart rate and blood pressure response to 30 minutes upright on the tilt table. So this was kind of reflecting what was out there in the literature. But they had come up with a new technique for measuring brain blood flow. They would take a Doppler probe and put it on each internal carotid artery and each vertebral artery for about 30 seconds to capture the flow through each vessel. So over 2 minutes, they could get you the total cerebral blood flow, or at least the cerebral blood inflow. And so this group with a normal heart rate and blood pressure, you might have been tempted to dismiss as entirely normal. But when you look at the changes in cerebral blood flow during 30 minutes of tilt, the healthy people compared to supine had a 7% reduction. The entire group of ME/CFS patients had on average a 26% reduction, and 90% of them had a significantly greater reduction in brain blood flow compared to the controls. If you then break down that 26%, the ones who had a notable heart rate or blood pressure change were worse. But the people that one might have been tempted to dismiss, who had a normal heart rate and blood pressure response to tilt, actually had a 24% reduction in brain blood flow. So we think it's no wonder that they have trouble with lightheadedness, fatigue, trouble thinking and concentrating. Let me shift gears and talk about the clinical presentation and some of the other things we've learned over time. This is a typical patient that you all might see and that we have seen, healthy and active until 9 months before she came in. She had an insidious onset of fatigue, but by the time we saw her, she was sleeping up to 14 hours a night, awakening unrefreshed, and her mother had a terrific time getting her going in the morning. She would then take a shower. After the shower, she would have to lie down for 15 minutes. She would have to lie down the day after a relatively active day. She had trouble concentrating that was new. Her muscles were sore. She had headaches and dizziness, and as a result was unable to attend school. So what have we learned about onset? Well, we know that a post-infectious onset is common, and 10 to 13% of these patients who have infectious mono will meet the ME/CFS criteria at 6 months. And the main risk factor for perpetual symptoms for meeting criteria is the severity of the initial infection. We used to say that a gradual insidious onset was present in about 40%, but I think as we rethink matters after the COVID pandemic, yes, the severity of COVID is clearly a risk factor for meeting ME/CFS criteria, but the vast majority of pediatric patients have a very mild or even asymptomatic COVID infection, but still can meet ME/CFS criteria. So what we don't know in the past is how many of those patients that we thought had an insidious onset were truly post-infectious. We teach our residents that it's pretty uncommon to see this before the onset of puberty. So I ask them to think very hard and look very hard for other causes in children under the age of 10. Clearly, it can occur at a younger age. There is a female to male ratio of about 3 or 4 to 1 for reasons that remain unclear. And there's a heritable component. It's much more common for both identical twins than both fraternal twins to have the diagnosis. We also found and published in 1999 that it's much more common for those who have Ehlers-Danlos syndrome to meet the ME/CFS criteria. And when we looked at those with non-syndromic joint hypermobility, we found a threefold increased risk. So in the upper part of the slide, healthy individuals are in the yellow. They had a Beighton score of joint hypermobility, which I'll show you in a second. 24% of them were at a score of 4 or higher. These are likely to be your swimmers and gymnasts and dancers, for whom hypermobility is an advantage in their sports. But our ME/CFS patients, their median score was 4, and 60% of them met criteria for hypermobility. Now, they've been hypermobile since birth, so there needed to be a second hit to trigger symptoms, but this seems to be a genetic risk factor. We know that the impact in adults can be comparable to MS and congestive heart failure, and many are disabled. In pediatrics, it's the most common cause of prolonged school absence. And we did a cohort study in which we looked at the PEDS-QL score for our ME/CFS patients and for healthy individuals. And then we looked at some of the published scores for cystic fibrosis, eosinophilic gastroenteritis, diabetes, and sickle cell disease. And I think most people who are unfamiliar with this illness are surprised that ME/CFS patients are much more impaired than any of these other chronic conditions in childhood. Let's look at how we have approached the clinical evaluation. Obviously, history is key, but with adolescents, I think we need to supplement that history with questionnaires that look especially at anxiety, mood, and cognition, because it's very difficult to get a sense of those things just from the child in front of you. We do a careful neurologic exam in all of our patients. We add a Beighton score for hypermobility, and we do some range of motion testing that is usually done by physical therapists, but which we find very helpful. The screening laboratories are the ones that you see here, where you get a blood count, some measure of inflammation, the serum chemistries, thyroid studies, and a urinalysis. And we check for iron deficiency, vitamin B12 deficiency, and we look to make sure that they don't have celiac disease. Beyond that, we only get other laboratory studies as clinically indicated. The history, we want to know about the abrupt versus gradual onset, whether there were any other events, what a typical day looks like for them, whether they have to take naps, whether the illness has caused them to have a big impact on their school or social activities. We look for evidence of a crash after activity, or PEM. And in particular with adolescents, it's important to ask them about uh, orthostatic intolerance in a specific way, because many of them think that everybody gets lightheaded when they stand. So we want to know, how do you do if you're standing in line at the store? How do you do in the shopping mall? And my joke with our trainees is that if you've got an adolescent who can't tolerate going to the mall, you've got an organic problem until proven otherwise. We also want to know, how do they do in the shower? Mainly looking for whether they have to sit down in the shower or can't need to take a rest afterwards. And we ask about their salt appetite. This is the Beighton score for joint hypermobility. You get a point on each side for bringing the pinky past 90 degrees, as you see here. 1 point on each side for the thumb coming to the forearm. A point on each side for more than 10 degrees of hyperextension at the elbows and the knees. And for this, we need a goniometer to measure the angle accurately. And then palms to the floor is the 9th point. The Beighton score is, if it's 4 or greater, at least in our studies, we consider that consistent with hypermobility. Others would say 5 is the appropriate Beighton score for adolescents. We do an in-office passive standing test where patients are supine for 5 minutes beforehand. We measure blood pressure and heart rate each minute, and we get them to score their fatigue, lightheadedness, cognitive fogginess, and headaches, as well as other symptoms on a 0 to 10 scale. We look for increases in those symptom severity scores as they stand, along with the changes in heart rate and blood pressure. We also find that it's helpful to measure the heart rate for another 2 minutes afterwards, because after they've gone through this test, they relax and their resting heart rate can be lower than it was in the pre-test period supine. Among some clinical discriminators of fatigue, those who have myasthenia gravis or some other neuromuscular cause usually have weakness, whereas our ME/CFS patients have normal strength. They typically don't have obstructive apnea, and those patients might have more daytime somnolence and snoring. Those with heart and lung disease are going to have shortness of breath during an effort, whereas the ME/CFS patients will be wiped out the next day. Adrenal insufficiency is quite uncommon, but those patients can look a lot like ME/CFS patients, but they will have a low serum sodium. They might, as time goes on, get bronzing of the skin. Hyperkalemia is a later phenomenon. And then Dan Hafez and a number of others have focused on the fact that a number of patients meeting criteria for ME/CFS have either Chiari malformation or cervical spinal stenosis. And we have seen the same in our patients, in a small subset of those with ME/CFS. So we look for an occipital headache, brisk reflexes, a lot of neck pain, and then we check for a Hoffman sign to see if there's something that would indicate a reason for getting an MRI. On the right is one of our patients who had a congenital narrowing of the cervical spine with very little spinal fluid on either side of the cord, and a small disc bulge that was compressing the cord at C6-7. When she had that disc bulge replaced by an artificial disc, 4 years of ME/CFS symptoms and POTS resolved, as did a good proportion of her anxiety. So it's particularly important to look for these neuroanatomic causes in people with persistent and refractory symptoms. We typically don't see weight loss in ME/CFS unless they have median arcuate ligament syndrome, something that you all in Germany are familiar with from the work of Dr. Skolbach in Leipzig, on the vascular compression problems that are so common in those with Ehlers-Danlos syndrome. Fevers are uncommon. They don't have symptoms of narcolepsy. They don't have the clubbing that you see with heart and lung disease, and they don't have the swollen joints that you see with rheumatologic problems. We look carefully for those abnormalities I mentioned on the neurologic exam. In terms of management, we know that randomized trial proven treatments are limited, in part because we have not had coordinated clinics focused on this the way they do for childhood sickle cell disease or childhood HIV. But that does not mean that you have to be a nihilist about therapy. Standard forms of symptomatic therapy are often effective for the orthostatic intolerance, their headaches, their pain. menstrual dysfunction, and other comorbid conditions. I mentioned earlier that the enthusiasm for CBT as a curative treatment has waned because the treatment effect sizes are modest, as they were in the PACE trial. No one has studied the severely affected patients. And then the PACE trial has come under criticism because of the data on research misconduct, where the analytic plan was changed during the analysis phase when people got access to the original data and used the original analytic plan. There was very little improvement from CBT, and that was published by Wilshire and colleagues in 2018. I did want to focus on one pediatric CBT study that was done in the Netherlands. They had patients get 10 hours of one-on-one internet therapy from a psychologist. The comparison group were people on the waiting list for CBT in whom there was no equivalent amount of attention paid. So David Tuller, who's a journalist who talks about these topics, wrote that here's what this study proved. 10 sessions of something lead to more reports of short-term benefits than no sessions of anything. But 10 sessions of what? Maybe 10 sessions of poker playing, or 10 sessions of watching Seinfeld reruns while holding hands with the therapist and singing The Girl from Ipanema in falsetto would have produced the same results. I think most of us would love to be able to write with that kind of colorful language. Our approach, which we published in the Pediatric Clinics of North America last August, really focuses on orthostatic intolerance, but it acknowledges that there are many, many other things that can go into symptoms either of the orthostatic intolerance or the ME/CFS. So I just wanted to highlight some of these in the next few slides, but would emphasize that this paper has all of the references you might need if you wanted to look into any of these other phenomena. One of the things that we look for carefully is evidence of cow's milk protein intolerance. In our cohort study, we found that 31% met criteria for cow's milk protein intolerance in the study. That meant they had a delayed reaction to cow's milk, no immediate anaphylactic reactions. This was not an IgE-mediated process. They had to have at least 2 of the 3 main symptoms of milk protein intolerance: epigastric pain, reflux, and early satiety. They then had to have improvement in their upper GI symptoms on a milk-free diet and at least 2 recurrences of those symptoms more than 2 hours after an open re-exposure to milk. And so we found a 31% prevalence, and those patients were sicker. They had worse health-related quality of life at baseline, but not after we had instituted a milk-free diet. And so if we suspect this, we get people on a 2-week period off milk protein, because if they continue ingesting milk while we're trying other medications, the entire process gets very confusing. We look for evidence of mast cell activation. These are patients from our clinic who have dermatographia, blotchy red rashes on the neck, hives elsewhere. This is our summer student who's doing research with us this month. Bright red changes in the face and ears. We don't know the true prevalence of mast cell activation, and it's a bit difficult to find the biomarkers for this or to capture those, but treating this with very simple antihistamines and other very benign drugs can be quite productive in the right patient. Another thing that we've done that I think has received very little confirmatory testing in the literature is that we find, even though most of the patients are hypermobile, they have a much higher prevalence of impaired range of motion if we employ tests done by physical therapists. And I won't go through all of these in great detail, but one is a seated slump test. There's an ankle dorsiflexion measurement, straight leg raise, and other abnormalities. And on all of these tests, ME/CFS patients have a numerically higher prevalence. And on this slide, I've shown you the ones that were statistically significantly different between the patients and the healthy controls, with odds ratios that are quite high between patients. We're currently trying to replicate this data, but this has been a consistent finding for us over the last really 15 years. I mentioned that we have had a number of patients with cervical spinal stenosis, and we wrote up that case series. So we look again carefully at the neurologic exam, and we emphasize that this is something to look for, especially in patients who are not responding to the usual interventions. Back to the 16-year-old I presented earlier. She had an examination that showed that she was acrocyanotic. She had an elevated Beighton score. We performed a passive standing test, and her heart rate went up 41 beats with reproduction of symptoms. So we had the diagnosis in our hands. Back in the early 90s, though, we were doing a tilt test in everybody. This again confirmed that she got fatigued, hot, lightheaded, nauseous, sweaty, and although her heart rate initially went up into the 120s, it plummeted at the 17-minute point when she was becoming hypotensive. So she had both POTS and the neurally mediated hypotension. And we treated her with an increase in salt and fluid along with fludrocortisone and potassium. She had an improvement in all of her symptoms within 2 weeks and was able to work 2 jobs, including feeding the livestock on the family farm. She was able to attend school completely without absences, and the only time she had fatigue was after 45 minutes of swimming. Obviously, this was an excellent outcome. They're not all that easy. When we repeated her standing tests, her heart rate only went up 10 beats rather than 41 beats on treatment. We followed her over time, and she would get mild fatigue when her allergies were active. But anytime we tried to wean the fludrocortisone, she would get a return of impressive fatigue, despite the fact that she was exercising and physically fit. So off the Florinef, her wellness score was in the 50 to 70 range. On it, it was 85 to 90. Over time, her resting blood pressure started creeping up, and we realized she could wean the Florinef when she was in her mid-20s. And she has fortunately not had any recurrences. These are the results that we saw in the wellness score improvements in our cohort study. They started with a mean of about 50 and went up to a score of 75 out of 100 by 24 months. But not everybody gets better. And this is a patient from that study who had an increase in symptoms after recurrent sinus infections at 13 and really couldn't attend school after she was about age 14 and is still housebound. We've identified multiple comorbid conditions, including POTS, low IgG, that is treated with subcutaneous gamma globulin. She has a low carnitine that even when we supplement her carnitine and the levels return to normal, she's still fatigued. She has migraines. She has some hives that look like mast cell activation. She has a number of problems with gut motility, and she has thoracic outlet syndrome and brachial plexus movement restrictions. We published a paper on that in January, and we're focusing on that in our current cohort study. So this is the kind of patient that we really need some better science to be able to help. So in conclusion, I hope I've shown you that ME/CFS is a serious chronic complex multi-system disease that often can profoundly limit the health and activity of affected patients. And in contrast to the obsolete early views, the examination is abnormal if you know what to look for. Acrocyanosis in 75%. In pediatrics, tachycardia or hypotension in greater than 95%. Joint hypermobility in 80%. And these movement restrictions that often are better picked up on by a physical therapist can be seen in more than 80%. And our view is that individuals with ME/CFS, both before and after the COVID pandemic, have a non-random increase in the prevalence of these comorbid conditions, such as joint hypermobility, the postural dysfunctions, mast cell activation, and others. And the importance of focusing on them is that each of those things offers a potential inroad to improving their function. We don't completely abandon CBT, but we don't offer it to everybody, and it certainly is not viewed as a curative treatment. Many of these symptoms are amenable to established therapies. I think we all agree that effective treatments for the more severely affected patients is critical, and that we need to expand our clinical care to address any inequities in care. I've listed a couple of resources. One is the international primer that a number of us published a few years ago. Our book on living well with orthostatic intolerance was published from the Johns Hopkins Press in August of last year. And then I wanted to list several webinars I've done for one of the patient groups here in the US. These are for those who want to dig in more on any of the topics we've talked about. And then there's the Institute of Medicine review of the data, a couple of chapters that I've done, some work by Kathy Rowe that might be of interest. Our website at Hopkins has a number of the papers that our group has published, so that might be an easy way to access those. And then you're all welcome to come and spend time with us, as Dr. Warlitz did. And just beware, Uta, that we will freely offer job offers for people to come to the United States, although I think that brain drain is going the other way right now. So these are the people who've helped us with our clinic. I'm going to stop there and see if we've got time for questions.
Thanks a lot, Peter, for this ME-CFS pitch. And we have a lot of time for questions, and I hope everybody will just ask anything he or she wanted to ask